everyone. Welcome back to the Principles of Global Health Equity. Today you're going to learn from Dr. Joia Mukherjee, who wrote the textbook on global health delivery. But she literally wrote the textbook. That's what you've been using throughout the course. So she's really a faculty member who needs no introduction. However, she is a professor, associate professor of global health equity at Harvard Medical School. She's also been the chief medical officer at Partners in Health for about the past 20 years. So enjoy her lecture on colonial medicine and its implications.
Hi there, GHD students. I'm super happy to be with you. My name is Joia Mukherjee. I am the Chief Medical Officer of Partners in Health, and I'm a member of your faculty at University of Global Health Equity, and I so wish we could all be together. But right now we have COVID times, so we're doing this online. I'm sitting here in my home in Boston, Massachusetts, where, as I said, I've been with Partners in Health now for over 20 years. And I'm also at Harvard Medical School, where I teach the Global Health Delivery Masters as well and run that program. And so it's really a pleasure to be talking to you about colonial medicine today. And I'm going to be sharing my screen here. Hopefully you'll be able to see it. Share screen. There's the slideshow. Okay. So we're going to talk about colonial medicine today. And let's see if I can change these slides or not. Oops. Okay. Got it. All right. So rather than calling it colonial medicine, what I prefer to call it is the colonial gaze in medicine. I think if we call it colonial medicine, it almost gives the opinions that the colonial project was about providing medical care for colonized people, and it really was not. And so we're going to address what colonial medicine is, what it is not, but let's think about it as the colonial view of medicine and what was important in medicine. And I want to, as much as possible, use voices of some of our great African thinkers. And so want to start out with this quote: "Until the lions have their own historians," and he didn't mean UGHE, but he might have, "the history of the hunt will always glorify the hunter." And that's Chinua Achebe, the great novelist and thinker, who really talked about who gets to write the story. And one of the things we talk about a lot at UGHE and with our equity agenda is who gets to write the story. And so we're going to think about colonial medicine a bit differently than we sometimes read in books, and we're going to think about who writes the story. So I want to talk about one particular word that's helpful to us in this exploration of social medicine, and that's political economy. Political economy is the study of how, I'm going to try to move my picture if I can, but I cannot. Okay, the study of how social and political theory intersects with monetary power and economics to influence situations. And I gave this random picture of a white dude with an American flag here to talk about political economy. So you could just see this person as a neutral person, as a person who maybe loves the United States. But if I told you that this person was at a rally against mask wearing in Detroit, Michigan, what you would understand about this picture is a variety of different political economy, different aspects of political economy that would tell you that this person is probably supporting President Trump, is probably supporting an anti-science agenda. That anti-science agenda is very much linked to people who want to open the economy and put the economy over the medical and the health needs of people. So that, without understanding the political economy of this man's action, you don't understand this picture. Now, if I told you that this man was one of the surviving jumpers, parachute jumpers in Normandy, and was at a celebration to celebrate the 40th anniversary of D-Day, which is a very famous American and Allied battle against the Nazis, you would think totally differently. Then you would situate this man in the political economy of the United States as an ally to other countries in the world in trying to fight fascism. So political economy is how we use the social and political context and even the economic context to really see how situations are influenced. So we will be asking all of you to always look at political economy, and we'll do so as well in this lecture with colonial medicine. So we talk a lot about the scramble for Africa, which we'll mention in a minute, but of course, Africa was never a blank slate, as all of you know. This is just a small sample of the many African kingdoms that were well established, many as early as 500 BC, and some in Ethiopia even longer. So in West Africa, in Eastern Africa, in Central and South Africa, there were so many kingdoms, and many were not even recorded. Of course, the recorded history, the written history in colonial languages also assumes that that someone from Europe had a hand in writing these. But as you can see, there are many, many kingdoms. And of course, we know the most ancient kingdoms were in Egypt and in the Middle East. And of course, the cradle of civilization itself right here in Rwanda and Tanzania and Eastern Africa. So I think it's very important to understand that civilization itself was started in Africa, that Africa is the richest continent, that Africa is home to so much of the history of mankind. And that is an important historical thing that we take into our discussion. So there were hundreds of African kingdoms that existed in previous eras, including the ancient era, and I said 300 or 500 BC, but it was 3600, sorry, BC to 500 of the Common Era. That's considered the ancient history, then post-classical history, and modern history, 1500 to the present. Yet, as we read books, we understand that Europeans discovered Africa. So going back to our Achebe quote, you know, if until the lions are the ones who write history. So we're hoping that many of you lions will write about the history in a way that represents the glorious things that happen among even today among African nations and her people. So going back to the question of who writes history, the Colonial Project. So if you look up just simply what is colonialism in the Stanford Encyclopedia of Philosophy, which I accessed just this month, colonialism is the subjugation of a people by another people. So just simple and quite neutral. Right? And I think one of the mistakes we make in looking at colonialism is the neutrality, is the lack of political economy. And instead, I would take a discussion of what colonialism is by Kwame Nkrumah, the first leader of independent Ghana, who said slavery was not born of racism, rather racism was a consequence of slavery. So in other words, the discrimination of people based on the color of their skin was a political economy, was useful to the enslaver. With this racial twist, Nkrumah goes on to say, was invented the myth of color inferiority. This myth supported the subsequent rape of our continent with its despoliation and continuing exploitation under the advanced forms of colonialism and imperialism. So you take a very neutral and sanitized definition given to us in the Stanford Encyclopedia of Philosophy, and then you take the much more brutal and the much more specific discussion of colonialism that comes from an African leader who fought for independence. And notice that he centers the idea of racism and the idea of color in central to the concept of colonialism. And so it goes often without saying, but I believe that it needs to be said that part of colonialism is a project of white supremacy and is a project to create and continue and perpetuate racial subjugation. And so part of this this colonial project, and even slightly before and during the colonial project, was the human plunder, the transatlantic slave trade, where millions of people, 12 million people, were sold into bondage and were the cogs on which the machine of the New World was built in North and South America and in some of the Middle East. Again, racism, according to Nkrumah, is this justification, the system by which one could justify the transatlantic slave trade. So a study of colonial medicine, to me, without looking at this racial devastation, destruction, white supremacy, is really very incomplete and really doesn't help us understand what the colonial project was. So remember those African kingdoms. This is a map many of you might have seen. This depicts the subdivisions of the continent under the scramble for Africa. This is the colonial flag map of Africa in 1939. And you can see this is very neatly divided into France and the UK and Spain, Italy even, and Portugal, etc., and even the United States, which often says it didn't have colonies, but there we have it. So of course, this was never, this territory never actually belonged to the Europeans, but they certainly took it, plundered the land, and exploited the people. So what is the purpose of colonialism? I think there is enough scholarship, enough evidence to say that the purpose was threefold: was extraction, extraction of wealth, gold, diamonds, cobalt, coltan, mahogany, and the use of public funds, often public funds from empire, from the UK, from the Dutch, from the French, to create infrastructure like railroads, to plunder the continent, to extract, but that those profits went to private companies. And many of those imperial and colonial companies are still in control of that wealth today. You look at Royal Dutch Shell from Nigeria, or Anglo Gold from the UK, or De Beers Diamonds from Holland. These are still the same colonial powers and private enterprises that had profited enormously from the exploitation of African land and people, as well as from public financing of the infrastructure, which was never put in place to help the African people, of course. A second purpose, of course, was enslavement of people. And of course, the formal enslavement is the most famous, the transatlantic shipment of enslaved people, but also debt bondage. And, you know, one of the boons, one of the big successes of the colonial project was free labor. forced labor. And so that took the form of sometimes forcing people into labor, as most famously was done in the Congo, but was done all over Africa, and Madagascar and Senegal and other places where people were tortured. If they didn't tap enough rubber, would have their hands chopped off, or put in terrible debt bondage. They were put into a house, and then they would have to pay from whatever were their earnings from mining for that house, very steep taxes, and that would put them into bondage. And then the pittance that people were paid for very difficult work. And then lastly, of course, empire. Part of the purpose of colonialism is power and strategy, strategic positions for the Navy, for the Army, and we see this even today. One of the largest ports, which is in Eritrea, is still has been in contention, and the whole Ethiopia-Eritrea situation, mishandled because and created and made more conflictual by the interest of the United States and the Saudis in the port there in Eritrea. So now I think we can get to health. We've said what colonialism was, what it wasn't. I think we don't have to claim that it was a civilizing mission. I think any of you who live in post-colonial societies, as most of you do, understand that the civilizing mission is very hypocritical. And so what about health? Well, there are several important things to think about health in the colonial period, and then think about medicine. First of all, terrible harms were caused by conquest from forced labor, as we talked about, withholding resources, torture. There was intentional and inadvertent introduction of pathogens to non-immune population. And this is well known with the Spanish in conquest of South America, with many outbreaks that were brought by Europeans into Africa, but even the purposeful infection of the indigenous Americans by blankets infested with smallpox by someone who later became knighted for his great contributions to the British Empire. And then there was the creation of tiered systems of segregation. Of course, the colonists preferred to wall off their communities, their cities, and many African scholars, including Fanon, have described the colonial cities as completely separate and devoid of Black people and Black Africans, but so was the medical system. There were many research and treatment campaigns without proper oversight, and we'll talk a little bit about some of those. And then I think also the undermining of indigenous practices. Now, we know that Western medicine today has a lot of very beneficial practices, and I'm not trying to advocate for traditional medicine, but when we remove the traditional healing, even spiritually, we often rob people of their culture and their connection to one another. So the undermining of those more traditional practices and beliefs and meaning. So let me just again talk a little bit about the African gaze of colonialism, and how we might think of life and death from the perspective of some African scholars. Membe Achille wrote about something called necropolitics. He took the social theories of Michel Foucault about biopower and took them a step further and said, when you add race into the equation, so you can talk about biopower or the power of the state over people, but when you add the concept of race and subjugation and colonialism, you move that from biopower to necropolitics, which is the idea that the state has the right to expose another to death, including the subjugation of their life and power to death. And so we see this in the colonial project in places like Congo and elsewhere, but we also see that even in the United States and how we have mass incarceration, that the state has chosen to use policies to subjugate and remove the life and liberty of particularly Black men in the United States. And so this is, you know, the view that it's not only the social theories that we've talked about, but also the social theories plus white supremacy and racism and how those become really deadly. And Frantz Fanon says the landing of the white man on Madagascar inflicted injury without measure. The consequences were not psychological alone, and he, of course, was a psychiatrist, but the relationships between consciousness and the social context. So while Chile is talking about the politics of life and death, Fanon is talking about the politics of mental colonization and the feeling of less than, and the notion of deracination, removing your being, your original being. So what is health in this context? If we again look at it from the African gaze, from trying to see where you know, how great thinkers who are African are thinking about this, what is health to a colonist? Then how do you think of colonial medicine? Well, there certainly was some medical care and research, and some was helpful. There was a lot of colonial medicine was based on the protection of settlers and their assets, right? What are their assets? Their assets might be people, it might be land, it might be commodities, might be animals. The notion of having a healthy workforce, so you can have laborers, but you need to keep them at least marginally healthy so they can do their labor. And then, of course, some were moved by compassion. So let's talk a little bit about medical care and research. The kind of father of tropical medicine was Sir Patrick Manson, who is a Scottish physician who did most of his work in China during the British imperial time in China. He was a doctor and a scientist. And he developed a lot of very important understanding. He did medical care and he did his own research. And some of his most important findings were around the mosquito as a vector of disease, specifically looking at the transmission of filariasis. He also advanced the hypothesis of mosquito as a vector for malaria, but he wasn't able to make that discovery in his lifetime. He cared for a lot of sick people, both native Chinese people as well as British colonists. And he has written some about, you know, being moved by the suffering of the Chinese natives. But at the same time, he forwarded this construct that race biologically is different. And this has been the continued harm of colonial medicine and the colonial project based on white supremacy and how we see health and human rights. He says, these are the great agents of natural selection. He's talking about these infectious diseases. The fittest to survive under these operations propagate the race and constitute its types. But this is but an extension of the Darwinian hypothesis for the formation of the varieties of man. The savage races exist by adapting themselves to circumstances. The more highly civilized races by adapting circumstances to themselves. So here's someone who was at one time, you know, the father of tropical medicine, made some great biological discoveries, but was really a believer in this idea that there is a biological phenomenon that constitutes race. And we know now in study after study that's not true, and yet it was just promoted again in the Journal of the American Medical Association. And these have been largely debunked. In 1950, there was an Institute of Medicine study in the United States saying race is not a biological construct. Race is a social construct. But you see this legacy dates back into the colonial period, the tropical medicine period. And I'll just quote someone from my own institution, Harvard. Troops, which are required for federal service in tropical lands, and here I believe he's speaking about the US occupation of the Philippines, might well be recruited from the Negroes to be permanently and contentedly in the colonies. Their constitution is pre-adapted to the tropical disease environment. Now he's talking about Black people who were enslaved people who were now second-class citizens in the United States in the 1900s. And Nathaniel Southgate Shaler was the dean of the scientific school at Harvard University. So this was being passed in the academy as part of the foundation of this colonial medicine, which is deeply rooted in a set of fictional biologic differences. And Nathaniel Southgate Shaler was also a believer in the polygenesis theory, which was the theory that different races came from different origin species and were literally a different kind of species. So this is all within the history of colonial medicine today. And one of the reasons that UGHE is so important is we want all of you to be scholars. We want the voice of Africans to be scholars on what can be done, what is possible, what needs to be done, instead of people who are looking from their white gaze and from their colonial gaze or from their white supremacist gaze. So the denial of common humanity was a very important part of colonial medicine. This polygenesis theory, the belief in different origins of different races, the religious theories, the tribes of Ham, Mark of Cain, the cognitive idea that, the actual size and shape of the skull, eugenics, the idea that there were genetic differences, and then the experimentation. And Adriana Petrina, who is an anthropologist, wrote a nice piece, When Experiments Travel, Clinical Trials in the Global Search for Human Subjects, on how even today, medicine has used the level of illness throughout the African continent and elsewhere as a testing ground for any variety of vaccines and medicines without really proper oversight. So what about protection of settlers and assets? Well, certainly some of the examples of this protection rackets in colonial medicine was the idea of segregation. Rather than upgrade the conditions overall in response to pandemics such as the 1918 flu, cholera, etc., there were many things done to segregate Native people from the settler population. One such act was called the Native Urban Areas Act, or the NUAA, in South Africa in 1923, which forbid Black Africans from living in white enclaves. Another report from Simpson, the 15 Simpson report in Kenya, was a set of public health recommendations to segregate Nairobi to prevent diseases to settlers from what was called the Indian Bazaar. So even within the immigrant group of Indians, to separate them from the white settlers and have a variety of color lines. So these were some of the means of protection, this kind of segregation and laws to separate people. And then in terms of assets, I think so much, as we said, of the Colonial Project is about resource extraction. So there is this concept that's been written about by some of my colleagues, Rafi Frankfurter, Paul Farmer, and others about Sierra Leone, but the concept of indirect rule. So you are sitting in Belgium or the UK and you are extracting resources, making a profit, and you're not there. So how do you lord your power over people? Well, often it's by developing complicity of middle class people, of creating special chiefdoms, which was done in Sierra Leone, where the British actually rewrote the map of chiefdoms. And that indirect rule allows you to extract resources without dirtying your own hands. This, as I said, needs complicity of local leaders. And then those local leaders are the ones who have to manage the fallout. Sometimes in the situation of mines, for example, and in the article I'm referring to was about Sierra Leone and the diamond mines in Sierra Leone, which are controlled by a variety of different interests, including the South African mercenary group Executive Outcomes. But occasionally these companies will realize that, wow, they better provide health for their workers because it's too expensive to replace the workers. So there was an interesting thing that happened right at the time of the HIV epidemic first getting very severe in Southern Africa, where some of the mining companies said, well, I guess we better treat our workers because every time a worker dies, it costs us more money to replace them. So is that valuing the life and the humanity of the worker, or is it just about the profit? Well, of course, it's really a profit kind of table, plus minus. This is a picture of the famous Marikana mining strike, where workers demanded a fair wage and access to health care, and they were able to get some of their demands met. But unfortunately, often the whole notion of providing healthcare, it may be just for profit or even under this idea of corporate responsibility. And the problem with corporate responsibility is that there's no oversight. There's no legal structure for it. So there's one partnership that I've given you the reference to called the De Beers Soul City Partnership. It's in South Africa. And an article showed about educating the community about behavior change. Now, educating a community of men who are mining, who have no access to water, to healthcare, to proper food, are not able to bring their families to live in the mine about behavior change is really, you know, a kind of odd project, but probably many millions of dollars were spent on this project. And they did show that people gain knowledge about HIV. But what they also commented on in the paper is that there was inadequate attention to the contextual factors. And so, of course, this is an old picture from the colonial times of De Beers, a De Beers mine. And as you can see, all the miners are Black, and of course, all the profits go to white people. So lastly, compassion. Obviously, some colonial doctors decried the conditions of Indigenous people and the segregation of the healthcare system. And some lay people were trained during the colonial project to perform basic care. And we still see this in the training of lay community health workers and others. There were no formal training programs for doctors until the 1920s in Africa, Makerere being one of the very first medical universities in neighboring Uganda. But many of the programs, and we will continue to talk to you all about this, many of the programs were very vertical and geared toward infectious diseases, and particularly easily preventable diseases. And this is a picture from the cover of the book Global Health 101, not the books you've read. But when you look at this picture, and you know, again, I wish we were together because I'd love to get your feedback. But when I see this picture on the cover of a book, it does not show me empowerment. It does not show me equity. It shows me some kind of, like, as we say, noblesse oblige. Look how good I am giving you, this child, your polio drops. But if that child had a broken leg, if that child had a brain tumor, if that child, you know, had a mother who needed, you know, a mastectomy, like, this polio drop is obviously not enough. And I think even today, this is a current textbook that's out there, the idea of this compassion, and we're going to give you this drops, and I'm assuming that hand is a white hand, but maybe it's not, is really still, even driven by compassion, really about charity and a very minimalistic package of what we can give to people. So as we think about our roots of working together, you know, me as an American, you as Rwandans, Dr. Abebe as an Ethiopian, you know, Phaedra as a Canadian, I think. I hope for Phaedra's sake she's Canadian, not American. Well, you know, we want to work together in solidarity. And we hope to learn from all of you, and we hope to all learn together how to build power together rather than a hierarchical arrangement that will reproduce some of the terrible and fatal errors of the colonial period. And so that's one of the reasons I'm very proud to be at the University of Global Health Equity. So in conclusion, we know that colonialism resulted in death through disease, overcrowding, violence. Efforts in colonial medicine were really targeted toward the settlers. Some care and unregulated research was done. Very limited training of African professionals, and the focus was often on disease-specific campaigns, often using military tactics, and resulting in a big distrust of public health. And so I'll just leave it there and say there's a lot still to talk about, and I can't wait to be in Butaro with all of you, and we will talk soon.